So welcome to all of you today. We will start in just a moment. As we start, please allow me to share these brief instructions for participants. Please use the questions and answers box to ask questions today. The chat is for any technical issues or for introductions. Session recording and slides will be shared with all participants. This World AIDS Day, the International AIDS Society called on people everywhere to rally around the theme, Unite to Reach All. We must unite science, policy, and activism to ensure that all can seamlessly access the support and care they require. The voices of scientists, healthcare providers, policymakers, civil society, and people living with and affected by HIV need to come together to ensure that the benefits of scientific advancement reach everyone. The world has the means to end HIV as a threat to public health and individual well-being for all by 2030. We can only achieve this by addressing gaps in care, especially in low and middle income countries, reforming law and policy, improving access, and strengthening health systems. Today, we want to take a closer look at what it will take to reach all with HIV prevention. Despite progress in several countries, we are still not on track to end the HIV epidemic as a public health threat by 2030. In 2023, about 4,000 adults and children acquired HIV each day, a total of 1.3 million new HIV acquisitions. Median HIV prevalence among the adult population, ages 15 to 49, was 0.8 globally in 2023. However, because of marginalization, discrimination, and in some cases criminalization, median prevalence was higher among young women and girls and key populations. So let's look at the various HIV prevention interventions. Condoms remain a critical component of HIV prevention, but condom programming is still in crisis. Whilst awareness and attitudes to condom use are generally good or very good, significant gaps in condom use persist. Only 4 of these priority countries in Africa have distributed enough condoms to meet the need for condom use. More differentiated, equitable, people-centered approaches are needed for condom programming to achieve prevention targets. We are also not achieving our prevention goals with the currently available biomedical prevention products. With 7.5 million people having started pre-exposure prophylaxis, PrEP, to date, we will not achieve the global goal of 10 million PrEP initiations by 2025. In their review and commentary articles published this year, Alan Blitz and Meyer highlight that PEP, or post-exposure prophylaxis, has also been underutilized outside of occupational HIV exposure and in sexual assault cases. The multitude of barriers to PEP implementation include low client and provider awareness and acceptability, limited access to treatment and prevention services, and high rates of stigma. And what about an HIV vaccine? All current HIV vaccine action is in the laboratory, animal studies, or very early human trials. A lot has been learned about what does not work, since HIV is perhaps the most complex pathogen ever known. Nearly $17 billion was spent worldwide on HIV vaccine research from 2000 to 2021. UNAIDS and AVAC estimate that nearly $1 billion is spent annually, and this is important work to continue to be funded. HIV vaccine science and scientists continue to drive innovation and science that benefits other infectious diseases and global health in general, commented Dr. Nina Russell earlier this year, who directs HIV research at the Gates Foundation. Case in point, COVID. Thanks to HIV research, the mRNA vaccine technology was already available in 2020 to speed a coronavirus vaccine to market. Since 2003, 9 HIV vaccine trials have been completed, and only one trial, highlighted in red in this slide, has shown moderate efficacy. Key scientific hurdles that have hampered vaccine development are the unprecedented genetic variability of the virus, the rapid establishment of persistent viral latency, and the challenges associated with induction of broadly neutralizing antibodies. Clinical trials have been instrumental in evaluating scientific concepts and testing vaccine strategies. And despite the setbacks in vaccine trials over the past decade, we have witnessed incredible advances in HIV science, shifting us into a phase of truly game-changing breakthroughs. Innovations like long-acting injectable treatments and pre-exposure prophylaxis have transformed HIV prevention and care, allowing individuals to receive treatment or prevention every few months. As noted this week by Winnie Binyamina, Linda Gale Becker, and Matthew Cavanaugh, in the New England Journal of Medicine article, long-acting ARVs are the closest thing to a vaccine that the world has today, and they could support long and healthy lives for people living with HIV. Perhaps most important, they could be a tool for putting the lives of people living with or at risk of HIV at the center of the AIDS response. Despite significant advancements in long-acting PrEP and treatment, these technologies are largely out of reach in low and middle-income countries. High drug prices, restrictive licensing, and limiting manufacturing capabilities are likely to hinder the rollout of the long-acting PrEP products, cabotegravir and lenacapavir, while long-acting HIV treatment becoming accessible in the hardest hit regions is an even more distant prospect. So where to from here with HIV prevention? How do we make sure the people who need and want these products can access them? As outlined by the Global HIV Prevention Coalition, we need a strong focus on providing person-centered combination prevention to key populations and young people. Access will be enabled through community-based and community-led outreach, health facilities including sexual and reproductive health services, schools, the private sector, virtual platforms, and other innovations. Urgent action is needed to increase investments in HIV prevention, strengthen political leadership, and create an enabling environment to implement programs at scale towards the global target of fewer than 370,000 new HIV acquisitions annually by 2025. For millions, barriers such as inequities, stigma, discrimination, and harmful laws continue to stand in the way of comprehensive HIV care. For those who are not being reached are especially likely to be struggling with poverty and social inequalities, or to be members of key and affected populations, including men who have sex with men, sex workers, trans people, people who use drugs, migrants, and people in prisons and other closed settings. Less than 3% of resources were spent on HIV prevention for key populations. This investment gap must be bridged if we are to reach all. And what do we mean by person-centered HIV prevention? It's important to first define person-centered care within the HIV response. We define this as being respectful of and responsive to the needs, experiences, values, and preferences of the individual as a unique and whole person, considering the complex health needs of a person beyond only HIV treatment and prevention, their identity and the contexts in which they live, rather than focusing on the disease alone. Personalized, coordinated, and enabling person-centered care empowers people on HIV treatment or people seeking HIV prevention services. Focus on the person receiving care, the person providing the care, and the relationship between them. Treating people living with HIV or vulnerable to HIV acquisition as equal partners in planning, developing, and monitoring care. The client and their relationship with the healthcare provider are placed at the center of their care while helping people manage their health. It's not just only about the mechanics of the service. It also includes the relationship and care that underpins the service. Differentiated service delivery, DSD, is an example of a person-centered approach. It simplifies and adapts HIV services across the cascade of HIV care to reflect the preferences and expectations of various groups of people living with or at risk of acquiring HIV, while reducing unnecessary burdens on the health system. DSD approaches support expanding access, uptake, and PrEP continuation. Recently, service delivery changes during COVID-19 have further enabled a DSD approach for PrEP. First, on the when, is that many countries are now providing longer PrEP refills during the maintenance phase and requiring less frequent monitoring. On where, there has been greater decentralization out of health facilities and towards drop-in centers, pharmacies, mobile services, and other locations outside of the traditional brick-and-mortar primary healthcare facilities. On who, increasing the role of peers and expert clients is being realized. And finally, on the what, there is more acknowledgement of self-care technologies to support comprehensive prevention needs. WHO has led on providing timely updates to global guidance, including on PrEP service delivery. In 2022, they launched this implementation guidance using the building blocks and sharing how the building blocks could be adapted during PrEP initiation and initial follow-up versus during PrEP continuation. Importantly, you can see that just like with HIV treatment, there can be different building blocks for PrEP refills and PrEP clinical follow-up during the continuation phase. And looking ahead with long-acting PrEP, the idea would be the 6 to 12 monthly clinical visit. What other person-centered care approaches can be expected? What about self-injectable systems? What about more integration of self-management? What about co-formulations? There is a bright future with more innovation in the PrEP products that could be available: oral tablets, injections, implants, and patches. PrEP has historically been used almost exclusively for occupational HIV exposure and in sexual assault cases. And given that PrEP efficacy relates to timely access, it's important to discuss how to get people access quickly. Earlier this year, WHO launched updated PrEP guidance, and it included new recommendations related to two of the building blocks. First, and critically, WHO recommends that PrEP should be delivered in community. This decentralization recommendation is critical to having PrEP go closer to people that need it, and in taking it out of just being at health facilities. Secondly, the task sharing, or WHO recommendation, is that task sharing should be employed to dispense, distribute, and monitor PrEP. Again, by expanding who can provide PrEP, we can make it accessible quicker to those who need it. In summary, person-centered care approaches like DSD for PrEP and PrEP can support us in reaching our global HIV goals positively, impacting access, uptake and persistence, and effective use. It's not about everyone getting the same thing. It's about everyone getting what they need to improve their situation. Our discussion today will focus on three main questions, which we have asked out our panelists to reflect on. Which communities do you see aligning around HIV prevention advocacy, and what is their shared mission? What would effective access to long-acting or sustained release biomedical prevention to HIV acquisition mean for you and your community? And what other healthcare services would you like to see integrated into HIV prevention services, and why? But first, let me introduce today's fantastic panelists and person-centered HIV prevention advocates. Yvette Raphael is a co-founder of the Advocacy for Prevention of HIV and AIDS in South Africa and a leader in the country's HIV prevention movement for young women. Michael Igodaro is the executive director of Global Black Gay Men Connect, an organization he co-founded to advocate for the rights and dignity of Black gay men globally. He is based currently in the United States. Beo Oliveira Leite is a PhD candidate in epidemiology at the Federal University of Bahia, Institute of Collective Health in Brazil, working in the field of public health, particularly concerning the healthcare of trans women and the epidemiology of HIV and its social and behavioral determinants. The IAS team will share the full bios of our panelists in the chat, and I will now invite each of them to introduce to their work and the community they advocate for, and with. So first, let's hear from Yvette, then from Michael, and then from Beo. Yvette, the floor is yours.
Thank you so much, Beatrice, and welcome everyone on this very important webinar. My name is Yvette Raphael, and as Beatrice mentioned, a co-founder, executive director of the Advocacy of the Prevention of HIV in Africa. Next slide, please. All right, our work and what we do at Advocates for the Prevention of HIV in Africa, I'm going to mention a few of the programs and a few of the strategies that we use for person-centered care. Our advocacy approach is around mobilization, engagement, accountability, mentorship, representation, and capacitation. Our programs that I would like to mention today is the Young People Speak session, which is a session led for and by young women every Wednesday that talks about HIV prevention and how HIV prevention affects them. We have the ground forces and champions who are based in the communities that we intend to empower with HIV prevention messages to be able to advocate for themselves. So we have the ground forces program as well as the champions program. Our ground forces program is a 2-year cohort program that looks to working with young people in their communities, and thereafter they actually get into our alumni program, which is the Champions program that helps building leadership in the country. We also have the engagement forums, which happens online but talks to a lot of the engagement with communities that work on sites, the community advisory boards, the global advisory boards, etc. Next slide, please. Our work goes from research to reality, and we engage at policy level. We do advocacy at all levels. We do HIV prevention work and information sharing, research literacy, and we fight and advocate for access, engaging those communities, and that leads into programming. Thank you. Next slide. So another one of the work that we do and champion for is the African Women's Prevention Community Accountability Board that engages women living with HIV who are also, and also women who are negative and leaders in the different countries. We have 14 women engaging in 17 countries that are part of the leadership of the African Women's Prevention Community Accountability Board. This group actually spearheaded and is part of the Choice Manifesto. Next slide, please. And the Choice Manifesto, our calls are clear. Its availability and access is necessary but insufficient. We understand that women and girls need to control their health and their bodies. Interventions must prioritize key and marginalized women and address stigma, discrimination, and criminalizations at all levels, facilitate participation of women, young people in research, prioritize integrated services, and also the assumed ability to adhere should not influence which products are offered. So we are actually leading the choice agenda, the Choice Manifesto. It's clear our some language check is that we understand there's a clear difference between options and choices. Options is effective and safe biomedical methods that are made available, and it requires research and development of additional options to add to method mix. We understand choice to be the ability for women, young people, and individuals to get into a center and get an array of options, and it requires policymakers, donors, our government's implementers to make the method mix available, accessible, and affordable. I'd like to get to the next slide. One of our highlights for this year as an organization is our Prevolution Bootcamp, where we brought together over 50 young people in South Africa from different organizations to talk around HIV prevention choice, as well as for us to understand that we have many products that to choose from to prevent new HIV acquisitions. However, these are not available. What we need in our country is a united champions, ambassadors, influence, demand creators, especially from the work that we do with the ground forces, peer ambassadors, champions, and young people. We also do understand that this work we cannot do on our own. We need a lot of partnerships, coalitions, and initiatives to ensure that this happens. We are part of the Coalition to Accelerate and Support Prevention Research. We work closely with AVAC, which you've mentioned in your slides, Beatrice, the African Women's Prevention Community Accountability Board, the Young Women's Prevention Council. But in our country as well, we work closely with SATAC. We work closely with the Desmond Tutu Foundation. In the region, we work with AFNI and many other organizations that support or networks that supports the work that we do. Thank you. Next slide. I'd also like to just disclose our funders. We are funded by PEPFAR, USAID, CASPA program through AVAC, and thank you very much for this opportunity to just shine a little bit of light on the work that we do, especially with women and young young people in South Africa, to ensure that the methods that we that are in research, we can not only become available, but people understand and use them. Lillian Moreko always says, we cannot demand what we do not know exists. And I say, what if we create all these methods and nobody wants to use them because they don't have information? So thank you again, Beatrice and IAS, for this opportunity to present our work. Thank you.
Amazing. Thank you so much, Yvette. And now we would like to hear from our beautiful Michael Igodaro.
Thank you, and it's always a pleasure to be speaking alongside Yvette. Always an honor, actually, to speak alongside her. Hi, everyone. My name is Michael Igodaro. I am the Executive Director of Global Black Gay Men Connect. GPGMC is a global network of Black gay men and led organizations around the world. We are currently based in New York City, but also have an office in Paris and in Joburg. Good to be here. So I just want to go through a couple of our work and specifically about our network, which is the global network of key populations and HIV prevention. Next slides. Yeah, I mean, I think, Breaches already spoke a little bit about this earlier on, so I'm not going to dwell on this, but I think our work is centered around the disproportionate effects of HIV among Black gay men. So I'm not going to talk about this. I think I'm just going to go to the next slides. Great. So I think all of this work that we do are led by, again, the Global Key Population HIV Prevention Advocacy Group. This group is a 14-member key populations, including transgender, people living with HIV, sex workers, PWIDs, and MSM around the world. They were formed 3 years ago in conjunction with AVAC and Gates to look at key populations and HIV prevention priorities. Next slide. Great. We've had several convenings. Our first convening was a global key population and HIV prevention workshop that was held in Johannesburg 2 years ago. This workshop brought together key population stakeholders, government, and private sectors to think about what does prevention look like for key populations. At this convening, we sort of drafted the first initial key population and HIV prevention roadmap. And I'm going to go through some of the highlights from the roadmap. Next slides. Great. The roadmap center had four priority areas. One of them is funding. I know it's easy to talk about funding, but funding is crucial for key populations-led initiatives. So funding to center the response of programs and to support key populations, but also funding that is, as we know, has been disproportionately cut for key population around structural interventions, around funding mechanisms for movement building, around funding mechanisms for community-based organizations to continue to do the work that they need to do. The other one is human rights. I think this is also key and crucial for any HIV prevention efforts. As we know, as we've seen in Uganda, in Ghana, in Zambia, in Tanzania, we see increasing human rights violations of key populations, especially LGBTQ communities. So again, this roadmap also centered the issue that around human rights that affects key populations. And then the fourth one is really around PrEP, pre-exposure prophylaxis. I think it's key, as we've seen, key population engagement in designing and being part of any product needs to be crucial. PrEP, as we've seen in Africa and Latin America and in Europe and in the US, MSM are centered to the implementation and design, but also when it comes to rollout, we are always the last phase of it. So we thought it's crucial for us to be engaged in designing demand creation, but also implementation, including long-acting PrEP as well. Also, the fourth agenda for this roadmap included U equals U. For those who doesn't know what U equals U mean undetectable equals untransmittable, which is also a prevention method. We think it's crucial for key populations to be involved in how we design messaging around U equals U and to make sure our communities are engaged in the messaging, but also translating it to our communities as well. Next slide. Right. I think structural interventions are key. Part of our agenda for the prevention roadmap was also looking at structural intervention. I think Beatrice spoke a little bit about this earlier on as well. I think we designed a fact sheet looking at what the structural interventions looks like for key populations. And these are key four aspects that we looked at as well. Structural interventions need to be defined as interventions that aim to overcome social exclusion of and marginalized communities. So looking at what does that structural interventions look like, I think a project that has actually done this really well is the PEPFAR Dreams programs that look at programs like back to school programs, housing, and human rights issues, as well as gender-based violence interventions. So those are like structural interventions that need to accompany prevention programs as well. Next slides. Great. I think, we think about what does community-led response look like. As part of the global KP HIV prevention roadmap and also the work that we've done in the last year, this year, we're launching a 3-year project funded by Gilead, ViiV, and MSD, which look at, to expand prevention for key populations, especially long-acting PrEP. This project is looking at, sorry. This project is looking at what does demand creation and forecasting look like for key populations and long-acting PrEP. I think we all are very excited about what long-acting PrEP promises, but also we don't really know how many KPs are there, how many of them are wanted, where are they, and how would they want it. So this project is looking with AVAC is looking like how do we forecast? How do we look at demand generation that is led by communities? And how do we make sure we design programs and target to meet key populations where they are? So we're really, really excited about this program to look at, market assessment, demand forecasting, and human-centered design to approach to see how we are making sure we are not making the same mistakes we made with oral PrEP, and to make sure our campaign are really looking at key population and meet them where they are. Next slide. Great. So that's it. I'm looking forward to talk more about all of this project, and again, very, very excited to be speaking on this with Yvette, and also thank you to IAS for inviting me.
Thank you so much. That was a fantastic overview, Michael. And now we will move to Bill. Bill, the floor is yours, please.
So, hi everyone, and thank you for having me here, and thank you for the opportunity. I'm Bel. I'm a transgender woman from Brazil. I'm a pharmacist and researcher on the PrEP 1519 project in Brazil. We act in 3 different sites here in Brazil, in Salvador, Belo Horizonte, and São Paulo. So we promote different health, sexual health, and prevention strategies for adolescents 15 to 19 years old from LGBTQ plus population. So the main objective of the study is to evaluate the implementation model for combining prevention, especially PrEP, 2 products of PrEP that we provide. So we provide 3 of these 2 products of PrEP. We provide 3 PrEP modalities: daily oral, event-driven PrEP, and long-acting injectable for these adolescents from LGBTQ population. So this is our clinic in Salvador. It's a very welcoming and colorful and friendly space, especially prepared for these adolescents from LGBTQ population. So we are based on, we are focused on person-centered services and integrative and comprehensive services and strategies for these adolescents. So we not only offer combined prevention, but also physical prevention, social support, and mental health for these adolescents. And now I'd like to show you, next slide, please. I'd like to show you a really short video about our participants that are speaking about choices and the experience of PrEP in our study. So please enjoy it.
A epidemia do HIV na comunidade LGBT, meio que a gente pode evitar isso com os anúncios da PrEP, como usar a PrEP, para que serve a PrEP, como ela funciona, porque essas informações são bem úteis.
Acho que é questão de abrir um pouco mais da mente, sabe? Acho que nós mesmos da comunidade, a gente tem muito aqueles estigmas que a própria sociedade impôs sobre a gente, né? E a gente às vezes não quer sair daquele lugar em que já colocaram a gente.
Acho que a divulgação entre nós, né? A gente conhece um amigo conhece outro amigo, que conhece outro amigo de outro amigo.
Continuando a passar informação, né, que é importante. E com isso, eu acho que você vai normalizar essas informações, porque as pessoas vão acabar se acostumando. Quanto mais traz, mais se acostuma.
Começando a PrEP me ajudou muito, porque agora me sinto protegido o tempo todo e fiquei mais atento à minha saúde sexual.
Eu estou usando a PrEP sob demanda e eu escolhi ela por justamente a facilidade, digamos assim. Alguns podem achar que não é fácil usar, mas para quem já tem uma rotina, né, sabe se controlar direitinho, é melhor, acaba sendo melhor.
Eu uso agora a PrEP injetável E eu escolhi ela basicamente por conta de ser mais prático mesmo, da praticidade.
Eu uso PrEP diária porque eu acho mais fácil de manter uma rotina fixa e sinto que me dá uma proteção constante. Eu acho ótimo ter opções, pois cada pessoa pode escolher o método que melhor se adapta ao seu estilo de vida e às suas necessidades.
Eu acho que para o futuro, se os colégios, as escolas se interessassem e passassem essas informações.
Educação sexual abrangente, precisamos desmistificar métodos preventivos.
Eu acho que a gente precisa entender que somos nós por nós mesmos. A gente vê, então a gente pesquisa na internet, a gente fala um com os outros, mas a gente precisa de uma fonte confiável, sabe? A gente precisa de algo ali que de fato traga os fatos e expliquem pra gente muitas coisas que a gente ainda não sabe.
Através das escolas, por exemplo, faculdades, em casa, por exemplo, também, né? Tem que ter essa maturidade e educação.
So this is our sponsors and partnerships. So I'd like to thank you again. And I think this video can give us different insights for the discussion about choices of the combined prevention and autonomy of the individual. So thank you.
Thank you so much, Bill. It was a really very nice presentation and video. So I would like now for us to move into the questions session, part of our session. And I would like to ask my first question to Yvette, and then would please ask Michael and you, Bill, to comment on as well. So as an HIV prevention advocate, Yvette, what does Unite to Reach All mean to you? What do you think most needs to hear this message to unite? Which communities do you see aligning around HIV prevention advocacy, and what is their shared mission? Can you give us your insights, Yvette?
Thank you so much, Beatrice. I think first of all, we need to remember that the people who are mostly affected by HIV and HIV would be the ones leading the HIV advocacy. For now in South Africa, we know our challenges is the new acquisitions for adolescent girls and young women, and we are working around the clock to make sure that young women are able to access HIV prevention methods where they go currently. We know in our demonstration studies, implementation science study sites, young women can access choice, and we are looking at at some of the results of those and what young people prefer. We also know that even in our communities where HIV prevention advocacy is happening, young people are able to access and ask for these methods, and by creating a demand to ensure that when these methods become available, young people, our government look at providing those for them. The HIV prevention landscape is not an easy one. And like I say to many people, is that unlike treatment, we do not have the same sympathy for people who are healthy. And that is one of the reasons why we feel that there's a slow move. But the prevention is the future. If we want young people, and we would like to encourage young people, we'd like to encourage women to take up HIV prevention methods, even if they think they are not at risk. So the question around risk should be one of where I am at and what are my chances of getting acquiring HIV as a human being. We see a lot in my community, women living with HIV gathering around this, uniting around this, because we do not want to see young people actually acquiring HIV. So it's important that we understand the leadership, the face of HIV prevention would look like the communities that needs it the most. Somebody asked me over the past week, who would that be? And I explained that that would be the mothers, the women who understand what it is to stand in front of a crowd and say, my name is Yvette and I'm living with HIV, and how we do not want that to be the same story for our girls. However, we need, like Michael mentioned, we need support, we need resources to ensure that a boot camp like the one we held, and I showed everyone here, it's creating that encouragement for young people. What I'd like to see is also a lot of young people, and that is what we also discuss in our sessions with young people, is we'd like to hear young people who are HIV negative say, I am HIV negative and I'm on a prevention method, so that they are able to influence their peers. And Bio's video showed that young people can talk about HIV prevention and lead the discourse. HIV prevention is the past. We also need to rally around ensuring that young people have enough information to be able to influence the discourse. We see that we have so many HIV prevention. For the first time, do we have many HIV prevention options available? But the mistake we should not make is to think that one option will solve the problem. We have the ring, we have Cabernet, we have lenacapavir, we have condoms, we have VMMC, you mentioned PEP. All of those needs to become where the young people are, and we all need to rally around. I don't even think when we talk about unite, I think everybody needs to unite. Everybody needs to unite to ensure that key populations are able to access their services where they need it the most. So I'd end there. Thank you so much.
Thank you very much for your insights, Yvette. And Michael, would you please add your thoughts?
Yeah, I mean, I think Yvette has said everything I wanted to say, actually. So, I think, no,
You
absolutely.
always have a beautiful word, Michael.
I wanted to say, I think it's absolutely crucial. I think, when it comes to unite to reach all, I think key populations right now, we're just starting to get on the train. I use this analogy to say, the train has left the train station for key population when it comes to prevention, and we're just chasing the train, trying to get in, because there's so much that's been left for us to catch up on. And so right now, we're just trying to catch up. As you can see in different countries, when it comes to PrEP access and who is sex in PrEP, you can see the number of dropouts, the number of low follow-ups. It's almost among key populations, transgender people, men who have sex with men, black gay men, almost left behind. And sometimes we have to ask why. It's not because we don't need this product, we don't want it. It's because we have low information about it. And there's not been a lot of demand literacy information to share with key populations about this product. How do you take a product you don't really know more about? So I think it's like we need to invest in literacy, and so we need to unite to reach all. We need to make sure key populations are the one leading the messaging about this product and are the one leading the translation of this messaging about this product, because it's crucial for us to understand the impact and effect and how these products were designed. Again, sometimes we feel like when we've engaged one or two KPs, we've engaged all. And that's not it. We have to make sure we fund those KPs we've engaged to make sure they can translate this information in their communities. Like the workshop that Yvette spoke about in Johannesburg, we have to make sure we fund such initiatives more, because that's where this information can be translated on the ground. And I think the work we've done with the Global KP Prevention Advisory Group is really doing that. We support communities to make sure they come to the highest level of researchers, and they go to conferences, and we support them to go back to their country to translate this information, to transcribe the very sometimes complex scientific information, to make sure that communities can understand what they're saying. And through the project we are just launching this year, which we're all very excited about, it's an impact of advocacy that we've run to make sure we can take back before we launch long-acting PrEP in global scale. We need to ask KPs, how do they want it? Right? What do they want? Sometimes we assume that because it's long acting, it's once every month or once every 2 months or once every 6 months, it's injectable, it's oral. KPs will just jump into it without actually asking them how they want it. So that's why we wanted to take a step back to make sure we can go to our communities and go back to the early days when we were messaging about condoms and lubricants. How did we get our communities to understand condoms and lubricants? That's what we're going back to do right now, to make sure our communities, MSM, transgender people, PWIDs, young women understand how this complex product were designed so they can make the choice for themselves and so they can decide if they want it or not.
That's excellent. I wish you could expand your work to Latin America as well. So, Bill, would you like to add anything, please?
Yeah, thanks. I definitely agree with all the thoughts. Just adding some different thoughts now. I feel sometimes that advocacy for the end of HIV epidemic is often promoted only by few researchers, I feel policymakers, and above all, key population, especially in my country when I think about Brazil or other countries. So what you can see with this, it's like it's a niche. So when I think of Unite to Reach All, it's about everyone, everybody realizing the significance of working towards of the goal of ending HIV epidemic, whether it's for prevention or treatment or care. Not only do I, as a trans woman, need to work together with my community that is most vulnerable to HIV, but we need to expand and reach out to everyone so that they understand. We need to talk about this now. This issue matter. It has a big impact on public health, on health services, on the health services systems, on the government accounts. So I believe that the people who need special attention now the most are those outside of our social bubbles, of our out of advocacy bubbles. We need to reach them and make them understand the significance of this mission. We need to reach parliamentarians, policymakers, the big media, and expanding the diversity beyond the, for example, the Red December. We need to normalize talking about sexual health and prevention in schools, in communities, inside of neighborhoods. So we need to increase our health coverage so that it reach even the most vulnerable. So we need, for example, for young people, we need to create more demand creation strategies. We need to produce more information. We need to get inside of schools and get inside of the family, inside of the families, because the problem of misinformation is structural. So I think I believe we need to expand our information about prevention and all the cascade of HIV.
Thank you, Belle, for your precious insights. And I would like to follow another question to you, Belle, first. What would effective access to long-acting biomedical prevention to HIV acquisition mean for you and your community? Can you give specific examples of how this would improve the quality of life of members of your community, Belle?
Of course. So first, I believe that in the context of combined prevention, new options, especially different biomedical options, bring many benefits to people, especially the most vulnerable ones. When you give options, we give autonomy to people for the choices, different choices. So the meaning is, if you offer different options, you are creating individual autonomy and expanding access for prevention and care, especially for HIV. Second, when I think of an option such as long-acting sustained release that can facilitate adherence, facilitate access to health, and increase protection against HIV, we are expanding coverage and reaching more people, especially the most vulnerable ones. Another thing is when I think my community, especially trans community, which is completely withdrawn of the health services, face violence, discrimination, stigmatization, another kind of options can be really, really good for this, for my community. For example, it's like if you no longer need to take a pill every day, or remember to take 2 pills before and another after, and one more every time you have to have a sex. Now you can only take an injection on a pill or anything else every 2 months or 3 months or 6 months. So that's great and continues to protect you. So it's different perspectives, different strategies that can be good for most vulnerable ones. But of course, it needs to be available. These different these different biomedical strategies need to be available for everybody. So now recalling the speech of Winnie Bianima in opening of Ages 2024. So she spoke, bringing long-acting drugs to all low and middle income countries. So we know that those different technologies is still very, very expensive. So we need to make it accessible and available now for everyone. So I think it also means unite to reach all. Thank you.
Thanks very much, Belle. Michael, would you kindly add your insights, please?
Yeah, I mean, like I think long-acting products could be, again, we have several that are on the pipeline, including oral long-acting as well. So we are very excited about that. And I think they could, they are, and they could be transformational in terms of like reaching more people and meeting people where they are. But I think when we talk about choice, it's a choice until it's not. And so we need to, in certain countries where, where a lot of governments struggle to be able to fund these long-acting products, like how do we make sure we can get to the communities that really need it there? And how do we make sure we can work with our global donors? I know the production of those products are expensive, but also we need to make sure we are able to have equitable prices to make sure we get to people where they are. It will not be equitable if only people who can access long-acting PrEP are going to be people in developing countries. Or sometimes, as we can see, even developed countries do not want to buy those products themselves because they feel like it's too expensive, or they rather prefer generic products. So again, when we say it's choice, what about if the choice that's made available to you is the one only your government can afford? Then it's not a choice anymore. It's already been made for you. So we need to make sure we give it, we have access, equitable access, and we make sure we find a way to make sure it's accessible to all. And I think again, also not just access only, we have to make sure we get it to people who really need it the most. And again, I think we have to remove all of these barriers. We've already heard from countries that are currently implementing long-acting PrEP, where they have this, in my view, very, not necessarily supportive, like assessment tools. What are you assessing for people to get to long-acting PrEP, like risk assessment for long-acting PrEP? Why do you have to put in those other barriers that we currently have right now to make it even more difficult for people to access long-acting PrEP? What are you assessing? So I think we need to make sure, again, we remove those barriers that we put in place. Also talk about testing, right? The testing tools that we have right now are different for what we're going to be using for long-acting PrEP. So we need to evaluate those. We need to make sure we make it easier and simpler for people to access long-acting PrEP. And we need to work with WHO, with national health government, to make sure we put in policies and we put in implementations processes that makes people where they are, and not putting roadblocks that's going to make it even more difficult for folks to access long-acting PrEP. I think there's a long way to go, and we can hear from examples from Zambia, from Malawi, from countries that currently are implementing long-acting PrEP, to see how we can make sure we can scale the impact, we can scale it easily, not putting more roadblocks. I think again, what we've heard from oral PrEP, we've not done a good job. The last 10, 15 years, we've not done a good job in rolling out oral PrEP. We need to make sure we learn from our mistakes and support communities. Yes, we might not have PhD, but we have PhD in community engagement, and we need to be taken seriously.
Yes, I couldn't agree more with your words. And as you said before, increasing literacy in the communities is a first step that we really need to move towards. Yvette, would you please share your insights on this question?
Thank you so much. And I just want to say the previous speakers spoke at length about it, but we also need to understand that for us to be able to reach young people, we need to create spaces where they understand first HIV prevention, and also how do they engage with policy, their own government. So long-acting PrEP, HIV prevention has a huge space in our lives and in the prevention agenda. However, we need to make sure that young people understand what is needed from them. I just don't want to digress and miss the question around HIV for women, HIV prevention for women. We also need to continuously understand that spaces like IAS creates a platform for us to engage and also to understand that we have not reached the end to HIV/AIDS acquisitions or even AIDS, because so many people still do not understand HIV transmission, etc. We know that women still struggle so much with defending themselves and ensuring that they do not acquire HIV because of the kind of relationships that they are in. We need to work, when we say unite to all is making sure that everyone understands the role they play in HIV prevention. This is not only the the work of people living with HIV. This is not only the work of key populations. This is not only the work for young people. Everybody in our spaces, in our countries, in our communities, everybody needs to unite so that we are able to see an end to AIDS by 2030, as we mentioned. But I think long-acting has a great space, but people need to know what it's about. Like Michael said, one of the big things, and it's almost like deja vu, Michael. Remember when we were sitting in Kenya and said, this is too medicalized. People will never take half their days to go and sit and prevent themselves for HIV. We'd like to also ask, make HIV prevention cool, make it sexy, make it fun, make it easy so everybody can access it, and stop with making it difficult and just focusing on certain populations that ensure it is some of these prevention methods are stigmatized. We have many methods available. We would like to see all
Yes.
of them at the table. Thank you so much, Beatrice. I know
Thank you.
I went over
Yes.
time.
Yeah, so I would like to have a last question, but I want you please to keep 30 seconds response because we are just finishing our time, but I really want to hear you on this one. So to start with, Michael, what other healthcare services would you like to see integrated into HIV prevention services and why? Just very short answers, please.
Structural interventions is really crucial because HIV, for human-centered design, it needs to be important that we have the human in the design. The human needs to be part of the design. So structural interventions is key for HIV prevention.
Brilliant. Thank you. Yvette.
Yeah, Michael this time stole my word. So I would say family planning and SRHR services needs to be integrated, and that is really not rocket science. It's a no-brainer.
Thank you very much. Belle, please.
So I
Keep
think
it short.
Okay, so I think we already have learned about the HIV epidemic, so we need to create integrative services to take all of these components into account, like physical, social, and mental health. We need to offer social and mental support because the population most affected by HIV is the most vulnerable one, affected by misinformation, poverty, discrimination, and stigmatization. So we need to create comprehensive and integrative services thinking about that. Thank you.
Thank you so much. I couldn't really be more grateful to our brilliant panelists. I love it, our conversation, so thank you very much. I just want to reiterate that equitable access in all global regions is needed for long-acting PrEP and treatment to achieve their potential. We must work together to remove barriers and create solutions that will allow those with the greatest need to access the most effective forms of HIV prevention and treatment. We need to create health systems that involve communities, are adequately resourced, turn research into practical solutions, and are free of stigma and discrimination. I think it's very clear that reforming discriminatory laws and policies is critically essential to reducing HIV vulnerability. We must unite to advocate for reforms so everyone can access care without fear of harassment, discrimination, or legal consequences. We also need to collaborate beyond the HIV response. We need to focus on prevention to STIs and hepatitis too, of course, but also preventing future pandemics. We also need to support each other more. And this is very important as we grapple with the climate crisis, the multiple political crises, and finding cuts, wars, droughts, and famines that we are facing now and will face in the future. The answer is to unite to reach all with kindness and inclusivity. I would like again to thank you very much. The recording and slides from today's webinar will be freely available on the IAS Plus in the coming days, and a link shared with our registered webinar participants. And lastly, I would like to thank Gilead Sciences for their collaboration and support of the IAS Person-Centered Care Program. Thank you very much for joining us today. Bye-bye.